I failed to record the Zoom meeting last night, so I'm going to reconstruct it. It's fairly straightforward, a bit tedious sometimes, but it's answering the questions from the paper. So let's have a look. If I find it, we will. There we go. Okay, so let's try and do these in some sort of order. Question 14, if I'd strongly suggest you get, you look at your question paper when you're doing this. So 14, which one of the following would be least comfortable manipulating? An elite 18-year-old female athlete who is having normal menstrual periods, 50-year-old female who is still having normal menstrual periods, an elite 18-year-old female athlete who is not having menstrual periods, a 50-year-old man who has a history of heart problems and is taking half an aspirin a day. Okay, half an aspirin a day is a little over 100 milligrams usually. I think they usually run about 325. So we're looking at 175, I think it works out to. Most people, though, now taking aspirin prophylactically are taking 80 to 100 milligrams. This is not enough to worry you about bleeding. The 50-year-old female is still having normal menstrual periods, probably isn't osteoporotic, so it's not my major concern. And certainly the 18-year-old female athlete who are having normal menstrual periods is not my concern. So it leaves the 18-year-old girl who's not having periods, and that is pathological. And this is associated with osteoporosis. This is either because of overactivity, shutting the periods down, or malnutrition, bulimia, anorexia, and so on, or often a combination of both in athletes. So it would be the third one. 16. Positive sharp test, person test is characterized, actually this wasn't on there, but I'm doing it now anyway. Positive sharp person test is characterized by a clunk, the reproduction of arm and leg symptoms, a feeling of posterior translation, the reduction of arm or leg symptoms. We've been over this enough times, I really don't feel that I need to talk to you about this one. So just make sure that you understand which one of those it is, and there's only one of them that is correct. 17. The problem we had with this one was the fact that vertigo is listed in both columns. So this is a classification of the type of dizziness in column 1 with a description in column 2. Okay, so the first one is vertigo. You can't describe vertigo as vertigo in any meaningful way, so D isn't the correct answer. Vertigo is an illusion of spinning movements around whatever axis, but the room's spinning or you're spinning, but something is spinning. Oscillopsia is a swaying movement or a linear movement, so for that, B would be the answer. Type 1 dizziness, pre-syncope on non-specific dizziness, lightheadedness, wooziness, giddiness, and so on. Sorry, did I just say type 1? Type 1 will be vertigo. D, sorry. Type 1 is vertigo. Type 2 is, as I said, pre-syncope or non-specific vertigo. And type 3 is disequilibrium. So don't get confused by the fact that vertigo is in both columns. You can't describe vertigo by saying it's vertigo. It doesn't mean anything. That was 17. Now it is 19. Which of the following are components of Horner's syndrome? Where we got into an issue with this. Okay, so there's more than one answer here. Constricted pupil, enophthalmos. The others are basically the opposite, dilated pupil and sorry, I said enophthalmos. Let me do this again. Which of the following are components of Horner's syndrome? There's only one answer, sorry, and that is a constricted pupil. Dilated pupil isn't. Brachial plexopathy is not Horner's syndrome, nor is it a component of it, although with Pankow syndrome, the two occur together. Exophthalmos is usually thyroid, and it's certainly not the enophthalmos of Horner's, and skin whitening. And where we ran into trouble with this was one of the people on the Zoom session felt that there was a variant with a dilated pupil, which confused the hell out of me for a bit. But that's not true. What she was actually talking about is one way to test whether this is pre or post ganglionic is to put a solution of cocaine in the eye. Now, with one of them, and I believe it's preganglionic, the pupil will dilate. With the other, it won't dilate. But without that stimulus, the pupil is constricted. So that was 19. Okay, moving up to 22. 22 is, which of the following defines an atretic vertebral artery? It's smaller than its partner, it is less than 1 millimeter in diameter, it injects directly into the basal artery, it terminates as the posterior inferior cerebellar artery. This is a simple fact-based question, and you just need to know the answer. So make sure you do. Now, number 27. Vertebral artery fibromuscular dysplasia is, and again, this is another fact-based question. It's in your manual. It's also on the PowerPoints that I gave you, and I really don't want to get into this, but I did with the other group, so I will with you. Basically, it's an alternating dilation and constriction of the vessel wall. So these are pseudoaneurysms, and on an MRI or an MRA or other forms of imaging, contrast enhanced imaging, is defined, it's characterized as a string of pearls appearance. So let me see if I can get the whiteboard working. Stop the share for a second, go back to it, go to the whiteboard. And what you get is something like this. It can be very symmetrical and less symmetrical, but you get this, that. If I can do this right, there. So you get these areas where the walls are reasonable, and then these areas where it's weak and it dilates out. So these are basically serial aneurysms, and they're dangerous. Now, there's not a hell of a lot we can do about that. It's intracranial. Well, it's not the VB system is not the only area that gets this. You get this in peripheral arteries as well as spinal arteries and cranial arteries, but there's not much we can do about it, and I'm not sure we can really badly affect it. So it's something you should know because it is part of the congenital anomalies that occur in this system. And as I said, I think with this system, you really do need to understand about as much as you possibly can of it. Okay, that was 27. 28, an intramural tear is one where the adventitia is intact. Again, a fact-based question. You need to know what it is. So you need to know what an intramural tear is. And I'll show you again simply because I showed the other people. So we'll go to my expert and to scale diagrams. We'll have a look at it. So what you've got is three walls of the artery: adventitia, media, and intima. The intima is epithelium, it's where the blood is absorbed. Musculus basically supports the artery and constricts and dilates it. And the adventitia is fibrous coating on the artery. So what happens with an intramural tear is either the intima gets torn or the intima and the media get torn, and you're left with the outer coat intact. So the blood will normally run up there, but what it can do now is get behind this and just strip it away from the wall, and this will weaken the adventitia, and you end up with this happening. And it can rupture. I mean, generally, I believe ruptures within 10 or 12 days of the injury if it's going to rupture. It's called a pseudoaneurysm. It's not true aneurysm because the coat, all three coats are not involved in this. But it balloons out and then it can rupture because it's weak and it's not used to taking these stresses, and the muscular coat is. So there's another form of pseudoaneurysm as well, which is a radiographic term. And it's when you can see a loop of artery behind another artery, and it looks like an aneurysm on that artery. When you image it from a different perspective, you can see they're two separate arteries. But this is a pathological pseudoaneurysm. Okay, so that was 28, fact-based. Get the fact-based ones down. These are easy marks. You don't have to interpret too much. So that was 28, 29. Which of the following characterizes a pseudoaneurysm? Well, that's what we just talked about, so that's easy. The answer is in there, so you need to know what it is. And then it was question 40. Which one of the following statements is true regarding the incidence of vertebral artery injury from cervical manipulation? It is extremely high and in-depth discussions with the patient are necessary before treating. It is so low that it need not be discussed with the patient. It is a minor risk that should be discussed with the patient. There are no good studies available that determine the risk is what the risk is, and so no discussion is needed with the patient. Okay, now a lot of these are true in the first part, but not necessarily true in the second part. The first one is untrue in its first part. The risk isn't extremely high. If it was, nobody would be manipulating any more than anybody would be injecting lead into your bloodstream. So it's definitely not number one. It is so low that it need not be discussed with the patient. This does have some merit. We get back to the idea that you're depriving your patient of an effective, safe treatment by mentioning the word stroke. So there are ethical considerations in making the warning so dire that they won't take what is probably their better treatment given that condition. So this is not the correct answer though. There are no good studies available to determine the risk, and so no discussion is needed with the patient. That's true. Not that no need to discuss it with the patient, but the fact there are no good studies on this. If you look at the results of these studies, it runs anywhere from absolutely zero risk to 1 in 5,000. Now, 1 in 5,000 would stop everybody manipulating it, but there were flaws, serious flaws with that study. It was a California one by physicians who were seeing hindbrain strokes post manipulation, but there's a lot of flaws with that, and it doesn't match up with the others. Nobody really knows, in all honesty. They have done a relative risk study, which is in your manual, comparing a course of manipulation with a course of NSAIDs, and manipulation is something like 10 times safer than taking NSAIDs for the same pain. So if we're going to stop manipulating people's necks, then we need to stop giving them NSAIDs as well. The right answer, the correct answer to this is it is a minor risk that should be discussed with the patient, but I think you need to discuss it with the patient circumspectly and not mention trigger words if you can possibly avoid it, but give them as much information as they feel they need and you feel you need. We talked about informed consent before, and the fact is it's almost impossible to get informed consent. If you go to court with it and the patient said, I never really understood, yeah, they showed me all this stuff, but I really didn't understand the risk, then the patient hasn't been adequately informed. And you can't really explain the risk because, one, you don't know what the risk is, and how do you put this in terms that the patient will understand? Saying 1 in a million may not convey the information you want to get across, but we don't even know if it is 1 in a million. So you've got problems with this. Don't make the warning so dire, though, that you cannot give an effective treatment. Okay, I think that was pretty much all of the questions we discussed. This took a lot less time, much less time actually. So we got into a few other discussions, but that was the gist of it. So follow along with your paper. Now these questions are not, as I said before, you cannot pass the exam, this written test, by relying on the information you got in the class. This course is multimodal, and you've had all the information you need to get this test passed and passed well in all of the information I've given you. So you've got to put yourself out a bit and do a bit more than look back through your course notes, your class notes. Okay, guys? So we'll do the same thing again next week, and we'll keep on doing it as long as there's any questions for this right up until the time of the exam. For those of you in Edmonton, this is useful. I know we're talking about the exam, but all of this is about patient care. This is so we can use this as a directed study, and it doesn't hurt. So, as I say, either these questions will be on this exam in total. You may actually get this paper. More likely, though, you'll get another paper with similar questions and sometimes the same questions. So it's entirely up to you what you do, but understand you've got a responsibility to look further than just the class notes. Okay, guys? I'll talk to you next week. Take care, everybody. Bye-bye.